Dear guests, welcome back to the JCJoyAge International Symposium 2021. Before we start, we would like to remind you all that the event will be recorded. It will be available all night later, so you're more than welcome to share this with your colleagues and fellow researchers. Should you have any ideas and questions for our speakers, please feel free to type and send us through the chat box or the Q&A box anytime during the presentation. We'll collect these and address them later in the Q&A session. Today, we'll focus on the interventions for older adults with mental health needs, particularly people living with dementia and their carers. Living with dementia or caring for someone with dementia may affect our physical and mental well-being. Interventions for them are therefore very important. We are very honored to have two psychiatrists among us today, Dr. Joe Sadavoy and Dr. Wai-Chi Chen. Dr. Sadavoy is a professor of psychiatry in the Faculty of Medicine and Institute of Medical Sciences at the University of Toronto, the medical director of the Reitman Center for Alzheimer's Support and Training at Sinai Health, medical director of the Province of Ontario's Enhancing Care for Ontario Care Partners Dementia Program, and senior clinician scientist in the Lunenfeld Tannenbaum Research Institute at Sinai Health. Dr. Chen is a clinical associate professor of the Department of Psychiatry at the University of Hong Kong and the chief of service of the Department of Psychiatry at both Queen Mary Hospital and Gleneagles Hospital. In today's symposium, Dr. Sadavoy will share with us how evidence-based interventions can help sustain family carers in their challenging journey, and Dr. Chen will talk about the latest development of non-pharmacological interventions for people with dementia in Hong Kong. After their presentations, the speakers will take your questions and comments and interact with you in a Q&A session. So without further ado, let's pass the stage to Dr. Sadavoy. Dr. Sadavoy, please.
Hi, good morning, everyone. I first want to thank you and tell you how delighted I am to be here with you. I have many friends and colleagues in Hong Kong, and while the distances are great, the connection feels very warm and vibrant. I'm going to just get my slides up here. So my focus today is on dementia caregivers. We know, of course, that dementia is a very significant problem worldwide, but we still have very few interventions to deal with this medically. And so managing dementia is very much a matter of direct hands-on environmental, social, and interpersonal interaction. All presentations on dementia, I think, have to begin with the big numbers. There are 55 million people in the world, probably a gross underestimate. More than half of those live in low and middle income countries, and that number will go up. The total cost of dementia care is estimated at $1 trillion now and going up 9 times that. So about a quarter of all people with dementia live in China, and the prevalence there is about 6%. There's a higher prevalence in Canada and other places, but the absolute numbers are very high. Next. So everyone we know with dementia eventually requires care. They can't do it themselves, and this is largely provided at home by unpaid caregivers. 96% of people with dementia in lower and middle income countries live at home. That number is smaller in some other countries. But what it means then is that in those countries, almost the total burden of care for dementia is carried by unpaid caregivers at home. Next. This leads to immense costs and numbers of hours and burdens for families. By 2030, it's estimated that we'll need 65 million full-time equivalents to manage dementia in the world. You can imagine what would happen if all of those were translated into costs in healthcare systems. We wouldn't be able to handle that load in the healthcare system itself. Next. So dementia is a public health challenge, and most of the burden is in the community. The heaviest burden of all is on families who are untrained, often and generally unsupported, and they're highly vulnerable to physical and psychological impairment, especially women living at home with persons with dementia. Next. So what does it mean to be a caregiver? I want to show you this video clip of Robert. It's a bit stylized, but it, I think, conveys some key issues about caregiving. And I wonder if you could begin the presentation now. So just while we're setting this up, the video shows Robert.
I'm not going to be able to make it after all. Joan's having a bad day. I know. I'm sorry. Yeah, maybe another time. Okay, bye.
Family caregivers take on unpaid care for someone who is unable to care for themselves. Being a family caregiver is a risk factor for social isolation and burden. Caregivers tend to work alone and may not have time to maintain other relationships. In addition, people outside the family may withdraw, stop calling them, and therefore increase the isolation that caregivers feel.
I don't really think of myself as a caregiver. I'm a husband, looking after my wife who has Alzheimer's disease.
Caregivers who live with the person they are caring for are more likely to feel stressed and report that their physical and emotional health has suffered. Level of stress and impact on health increase as the number of hours of care provided go up.
Close out for you. Come on, we've got to go to the dentist. Stop it!
About half of family caregivers report feeling worried or anxious about their caregiving responsibilities. Their sleep is often disrupted, and they report feeling tired, irritable, and overwhelmed.
You look at that. That mall finally opened after all these years. Yeah, we should go, but maybe wait until the fanfare dies down. It won't be so crowded.
When am I going home?
You are home. We're home.
Caregivers often experience grief as the person they are caring for becomes increasingly unable to engage in relationships in the way they used to. This loss can be profound, but often goes unrecognized because, while the person is lost to the caregiver in many ways, he or she remains physically alive. When caregiving demands are high, caregivers aren't able to remain connected to friends and family or make a contribution to their community. They can become isolated and experience burden and depression. The Reitman Center's social innovation and training programs connect caregivers to information, skills, and support.
Okay. Can we put up the next slide, please? Next one. So I showed you this video because I wanted to highlight some of the things that you may have noticed that were not narrated, particularly the isolation and the aloneness that's inherent. It's an inside state for the caregiver. They trudge through their life often. Frequently, they're making apologies, as Robert did, for not being able to do things and disappointing others and themselves. Life is often unpredictable, and they can't plan for things because they don't know what's going to happen. There's constant daily demands, moment by moment, for this intimate care, eating, managing the apraxia of those eating utensils, and these time pressures that you saw, which are a major issue for caregivers, getting to appointments, managing planning. They do this without much response, either from the care recipient or often from others. And part of what they struggle with is loss of continuity of shared memories and a feeling sometimes of bewilderment at the symptoms that emerge, like Robert's wife not knowing that she was at home. Frustration, conflict, and anger are emotions that are commonly present, and communication breakdown is, of course, inherent in the disease, but there's this loss of partnership and love. Next sentence, next slide, please. Thank you. Subpopulations of caregivers are also at special risk with challenges. Most family caregivers, certainly in North America, are employed. So we wanted to know what the impact of that sandwiching was on them. There have been very few studies of dementia caregivers who are employees. There are many studies of others. So we did a national survey of over 1,800 employees in Canada, people looking after older adults. And we found, not surprisingly, but tellingly, I think, that employees who are concurrently caring for persons with dementia with medium and high demands caused by the dementia are much more vulnerable to impairments of their own personal well-being, as well as their productivity at work. So this has a lot of implications for the society and planners and funders and employers. Next slide, please. How then might we sustain caregivers through the years of dementia care and this ongoing pressure? Next slide. Caregiving, it goes through its own phases. They parallel the phases of the dementia illness itself, but from the perspective of the caregiver, the picture looks a little bit different. Next. I've divided these phases into 3 stages. People have done this in different ways. I'll tell you my perspective on it. Next. Okay, there's a list that comes up here. So if you'll just click on it. The diagnosis for caregivers in stage 1 is new. They have to adjust to new information. They often deny the reality of the situation, and they become aware of an uncertain future. Relationship changes, but they're mild at this point. The core of the relationship remains, and intimacy, caring are continuing, although there are irritations. Next. Communication remains relatively intact. Independent activity continues for the caregiver. They can still leave the care recipient alone. They're able to go out without a lot of major safety concerns. And the daily activities for the care recipient need a little support, but not a lot of supervision and ongoing maintenance. Coping generally for the caregiver is adequate, and they don't need a lot of additional care. And at this stage, their help seeking is minimal. Next. Stage 2 is marginal caring. And here, next, please. The diagnosis and its meaning are generally much more crystallized for the caregiver. They're not so uncertain about what this is and why it's there. The relationship is significantly impaired at this point, and increasingly so. Communication is intermittent. One caregiver said, "I forget what love is like," she said to me. And Rachel Hadas said, "The silence was the worst. Silence, not as in solitude or concentration, but as in living with, eating with, waking up beside someone who has nothing to say to you." Rachel Hadas is a poet and playwright. The caregiver now takes on much more increased responsibilities for all duties at home: finances, shopping, medical decisions. Should I go to the ER? What's happening to his medications? Diabetes management, diet, housing, travel. And supervision is now required. The caregiver now starts to feel much more trapped at home and that they can't make independent plans. Social isolation becomes more intense, either actual or perceived. And there's a need now for additional care and help at home. And this is where caregivers really begin to seek community services. So I say this to highlight the fact that when planning for caregiver support, one has to plan for the right intervention at the right phase. Next. Stage 3 I've called overwhelmed or terminal caregiving. It's not necessarily a long phase, but here the diagnosis is no longer an issue of dementia and so on, but much more behavior and frequently concurrent problems of weight loss and frailty and medical illness and management of immobility and so on. The relationship is severely impaired. Caregivers are in the intense feelings of isolation and also loss. And communication now is mostly nonverbal with the care recipient. Decisions and activities are all the responsibility of the caregiver. And they are overwhelmed and at this point no longer able to cope. They have fantasies of how to get out of this, and often these are guilt-induced fantasies of death as a release from what's happening. They can't leave it all unless they're fully replaced. They're trapped, and the entrapment induces hopelessness. Help seeking is focused on placement decisions, and this was driven home to me very profoundly about 10 days ago when a caregiver that I was dealing with, who had severe depression associated with her husband's severe dementing illness, just felt that she could not see a future for herself, and she committed suicide. So managing and dealing with caregivers is a profound and profoundly important issue. Next. With all of these problems, it's often difficult for clinicians to know how to assess caregivers. They're often left to the side, not only because they aren't the central issue commonly diagnosis is, but also because clinicians may not know exactly how to go about asking the questions necessary. Next. Caregivers are at risk of emotional and physical decline. There's lots of research on this. You can look at blood markers of stress and see the elevation of things like interleukins and C-reactive protein, and these markers that really interplay with the body's vulnerability to the physical impact of stress. Next. To assess family caregivers, we've developed the Dementia Caregiver Interview Guide. We just published on this about a month ago. It's called the DSIG. Next. And it takes, it's an interview guide rather than a scale. It's meant to guide the clinician in talking to the caregiver in key areas. So it measures, it evaluates years of care recipient factors like their behavior, their cognition and physical state, caregiver factors, the degree of entrapment, isolation, their own psychiatric history, the relationship history with the care recipient, their coping style, their knowledge of dementia, and barriers to change that they experience. Many caregivers feel a stigma and therefore won't reach for help. It examines environmental factors like support, family relations, barriers to accessing resources, There can be cultural barriers to feeling that you cannot ask for help. Protective factors in the caregiver are also looked at, things like their resilience and their satisfaction. And finally, there is a global measure on a Likert scale, this is a statement of the risk that the clinician feels is relevant to this caregiver. We've done a study on this. It seems to be a useful and acceptable and effective instrument. Next. Intervention is a whole other story. There have been about 200 or more interventions for caregivers that have been researched. Very few of these have actually been disseminated and scaled to any large size. But it's clear that the goals of intervention really enhance the caregiver's sense of coherence, their internal sense of competence, the ability to face challenges, and enhancing their resources of resistance to stress. Next. We've identified 6 elements for effective intervention. Of course, to enhance competence to manage internal and external challenges, enhancing the realistic acceptance of the diagnosis and the caregiver's practical ability to manage and seek out and use resources. Enhancing meaningfulness of caregiving, that is the worth of doing it, maintaining an inner sense of identity and relatedness, addressing interpersonal conflict between the caregiver and care recipient, conflicts, resolution, and grief. And finally, normalizing and contextualizing the experiences of the caregiver so they know they are part of a larger group and promote their connectedness. Next. So what works? Next. Principles of caregiver program development suggest from all of the research that effective models of intervention are multi-component, and they contain a few key elements. One is they are psychotherapeutic, and they have that component embedded. They're structured, they're specific to the needs of each caregiver, and they're tailored to the needs of the participants. They are of adequate duration of 6 months and of intensity that is adequate as well. Quick and dirty doesn't work in this process. And finally, the best programs address both the caregiver and the care recipient, although that's often not possible. Next. There are, as I said, few programs that have been scaled broadly for large populations. Our program is called Carers, and it is a multi-component intervention. There are others. There's the REACH program and the NYU, New York University, and family programs in the US, and the SMART program that was developed in the UK by Jill Livingston. These have all got research papers written about them. The most recent are in the last year or so, our papers and Sperling. Next. So what is our program of intervention? I'll tell you about that because that's the one I know best. And I think it's a useful model. Next. We've done, first of all, research to show the effectiveness of this program. We've published 3 papers. The most recent is a paper on 264 caregivers compared to a waitlist control. And we adjusted our measures and outcomes for the condition of the care recipient. And what we found was that the program was superior to usual care, significantly superior on measures of perceived stress, depression, burden, role overload, emotion, and avoidance-focused coping. So we've shown this really repeatedly, not only in our program at the Reitman Center, but also when we looked at the effectiveness of the program when it's been disseminated to other sites in the broadly scaled program. Next. The foundational principles of this program, starting from the top, include experiential learning for the caregiver, hands-on practicing. We use principles of adult learning. We incorporate problem-solving therapy techniques. We focus a lot on the development of the therapeutic relationship with the caregivers, and we are evidence-based. Next, I'll tell you just what I'm talking about here. We begin with a thorough assessment of each caregiver by a mental health clinician. We use that DSIG process, and we pay special attention to assessing emotions and relationships. Next. The carer's intervention is a manualized group psychotherapy program. There are 8 two-hour sessions. The first 4 sessions focus broadly on problem-solving technique. We teach caregivers how to do this. We do some dementia education, but only on topics and questions that are raised by the caregivers in the group. We do not do a lot of general education about dementia. So the first half of the program, the first 4 weeks, is problem solving. The second half is the hands-on simulation. We also provide individual support or referral to the resources for caregivers in need. Next. So I'll just tell you very briefly about these 2 elements of the program. PST is a research method for things like depression and anxiety. We've adapted it to address the problem-solving requirements of caregivers. So caregivers in the group, these groups are small. There are 4 to 6 people, caregivers. The caregivers are taught a method to control emotions and to convert abstract, complex caregiving problems into a practical, solvable form. So we are reducing chaos, focusing it, crystallizing it, and teaching the caregivers a method to do that. And it's quite systematized in 8 steps. The focus is on caregiver issues that are specific to each caregiver. So in each group, the caregivers talk about what they are experiencing now, and those are incorporated into the PST sessions and training. The goal is to reestablish in the caregivers a sense of mastery and competence with this method. Next. Simulation is a guided reenactment of a real, recent incident in the caregiver's life. Each caregiver has a chance to talk about what is going on, and these are simulated. There is a specially trained simulated patient who joins each group and who creates the scenario with a caregiver who volunteers to do that in the group, and they enact this part of the caregiver's life with the person with dementia. The standardized patient plays the person with dementia. The caregiver doesn't play. The caregiver is herself in this. I'll show you a video of how this works. During simulation, emotional challenges, relationship challenges, gaps in knowledge, skills, and attitudes are identified and coached. The caregiver begins to understand the relationship and emotions and learns new effective approaches. Next. Yes, thank you. We deal with all kinds of stuff in these scenarios, of course, paranoid accusations, unreasonable demands, various behaviors and managing confusion, agitation, family tension, and so forth. Next. So now I want to show you this video. It's about 7 minutes. It's a little long, but I wanted you to get a flavor of what happens with simulation. The caregiver is Robert. You saw him before. The clinician is Sarah, and the standardized patient, Mary. The group that is usually present when this simulation goes on and is watching and participating sometimes is not included in the video. This is for demonstration. Can you play the video, please?
In this video, the clinician guides Sid, who is caring for his wife, Magda, who has dementia, to deal with accusations and paranoia. Sid understands that his wife has dementia, but he doesn't always remember the ways in which dementia changes her abilities and her personality. When someone has dementia, the world around them can seem confusing. As part of their way of trying to understand what's going on around them, they sometimes make accusations or feel paranoid about other people's actions. The clinician guides Sid in new ways to cope with the challenge of providing caregiving when faced with accusations and paranoia, as well as deep feelings of grief and loss.
Okay, Sid. It sounds like the most important issues coming up for you this week are the accusations that Magda's been making. Would it be okay if we did some practice on those?
Oh, that would be really helpful if we could do something.
Okay, we'll see how we can help. The first step is explaining a bit of what's been going on and giving some of the details to Suzanne. Could you do that?
Okay. This week, Magda has been accusing me of stealing her purse, other things, anything she misplaces and can't find. She used to just get mad at herself, but now she's accusing me. So I was making breakfast yesterday morning, and she comes in saying, "You stole my purse, it's gone, all my money's gone," and she just keeps yelling. And I told her I wouldn't take your things. We're married. I don't need your money. I have my own. But she wouldn't listen. She wants to call the police. She keeps going on. And
when you say she's actually said, I want to call the police, or I will call the police.
Oh, I need to call the police.
I need to call the police.
Yeah, it's...
And you said she was yelling. So she was yelling right from the beginning?
Oh, yeah.
And
she was really upset.
Did it escalate? Did she get louder?
Yeah, I mean, she's yelling, and I'm trying to tell her I wouldn't steal anything, and I guess we just got louder, and even after I found her purse for her, she just put it in a drawer. She's still yelling and still wants to call the police.
And what was happening in her body? Was she pacing? Was she gesticulating?
No, she was just like standing in the door frame, and her hands were going and
waving her hands. Okay.
And pointing at me. She's accusing me. It's
okay. And
it's so upsetting.
Was she looking at you?
Yeah, I guess.
Pointing at you and looking right at you. And how did it end?
Well, we went out to the bedroom. I found her purse, but she's still yelling and wants to call the police. I was just too upset. I had to go out and just leave for a few minutes to try to calm down.
Okay. I think I have enough.
Okay. So it sounds like you already have one of the skills, which is taking a break. But let's do a couple run-throughs to see if we can give you some more skills in case this situation happens again. If you're comfortable, since this situation happened when you and Magda were standing, would it be okay if you both stand? And I might time out sometimes to maybe give some suggestions. If you're uncomfortable or it's not going how it usually does, you can just time out too. Okay?
Okay.
So whenever you're ready, the first time we're just going to do it exactly how it happened at home. So I'll get you to stand when you're ready and you can start.
Okay. It was just I'm chopping vegetables.
You stole my purse.
What?
My purse is gone.
What? I didn't steal your
gone.
purse.
Why did you take it?
I didn't steal your purse. I'm not going to steal your purse. Don't be silly.
I need to call the police.
You
All
can't
my
call the
money is
police.
gone.
Nothing got stolen.
All my money is gone.
I'm gonna
You just
time out. I can see that there's some emotions coming up for you. How are you feeling?
it's still upsetting just even doing it here, but yeah, I mean that's what happened.
What was it that was upsetting you the most?
Well, she was yelling. Magda was always very gentle. She didn't yell. We didn't yell at each other. So.
It's a big change in your relationship.
Yeah.
It sounds like it's a big loss for you too.
Yeah, she's a different person.
So, a hard situation and some grief coming up.
Yeah.
Would it be okay if we checked in with Suzanne about how this was for her?
Yeah.
Well, you weren't really looking at me, so you seemed guilty to me. I felt that you were guilty. Also, you kept trying to convince me that you wouldn't take my money, but as far as I'm concerned, it's missing, and I'm really worried about that my purse is missing, and I think you took it. So I'm just getting more agitated because I'm more worried.
What's it like to hear that?
It's like I'm making her upset.
I think there's some changes because of her dementia that are making her upset. One of the changes that's common is people with dementia have a harder time understanding logic. So I saw that you were doing the perfectly reasonable thing of explaining to her why that situation wasn't so, and using a lot of logic and a lot of words to explain something can be hard. So maybe avoiding some of that logic, using fewer words, and maybe also doing some connecting. So using a slower tone of voice or a lower tone of voice, touch, some eye contact, some ways to just connect with her as a person.
Okay.
Does that seem like you'd be willing to give it a try?
Yeah, I can try it.
It might take a couple
Yeah.
tries. Shall we try again?
Okay.
Okay.
So you get a sense of how those simulations go. The caregiver creates them in the moment, in the group. They talk to the standardized patient, tell them exactly what happens. Standardized patient makes nothing up. They just respond in the way that they were told the situation happened. And then at the end, when there's a timeout, the clinician provides some education where necessary, some guidance about how to behave and what to do. And the standardized patient gives feedback about how they felt as a person in that moment. The caregiver then does it again. And again, the coaching goes on. It usually takes about 3 run-throughs before the caregiver really gets the behavioral change. So we can talk a bit more about that if we have time. Just to end, I want to speak about what to do with a program like this. It's fine for small numbers of people, which is how we began. Our program's been running now about, 11 years. And but it's only in the last 3 years that we've gone from being project funded to being funded by the government to disseminate this program more broadly. And that was our challenge. It was to scale this intensive clinical program to address the needs of a large, diverse population. Next slide. So the elements of scaling, this is just our experience, was first to acquire base funding after we did research and bothered the government for quite a long time to do this, to fund us. We then developed a network of program delivery partners in all regions of our province of Ontario. I'll tell you about that in a sec. We staffed it at each site with trained clinicians. We trained all the clinicians. The sites hired them. We funded them with money that we got from the government. We ensured that the quality and fidelity to the program was maintained by establishing a memorandum of understanding with each site and giving them a job description for the hiring process for each clinician. These are multidisciplinary clinicians, by the way, often social workers, but psychologists and occupational therapy and others, nurses. We used outreach strategies to reach isolated or remote caregivers, and we addressed the needs in both urban and rural parts of the province. Our program is both a clinical program and also now the administrative hub. So we had to develop administration, communication, data collection for this what turned out to be a very large program. Nothing stays the same. We had to manage and continue to manage attrition, sometimes program failures and restarting in a different location. And finally, effective use of technology. All of our programs are now done both in person and online live. Next. The program is called the Enhancing Care for Ontario Care Partners. The Reitman Centre is the lead organization, and we provide all of these elements to the program. There are 12 satellite partner hub sites in both Alzheimer's societies and hospitals in the province. And they deliver the program in 36 urban and rural communities in Ontario. Ontario has a population of about 14.5 million people in over 1 million square kilometers. That's about 1/9 the size of China and bigger than Germany, France, or Spain. This is a very big area. Next. I won't go into any of the details. We certainly don't have time. But just to tell you that we've been operating now for 3 years, not at full capacity initially as we ramped up. And we've now served about 25, an older number, about 2,500 caregivers in our province. And as the program rolls, these numbers are more intense. We also have a website called dementiacarers.ca, which has a lot of resources for caregivers who don't need the intensity of this program yet. And we've got other elements of our program that we're developing now. So that's, I think, as much as we can do in the time that I have. Thank you for your attention.
Thank you, Professor Sadavoy, for sharing. And we really appreciate that you're spending your night with us. Canada is 12 hours behind Hong Kong, and you're staying up late for us. And for all the participants, we will upload the resources Professor Sadavoy has shared with us in the presentation to our research website. Just keep an eye on our research website, and then you'll find the resources. Okay, so thank you again for a presentation, and we can really see that how a sustainable and holistic support is important to dementia caregivers. And now we are going to talk about the local development, and we're passing the stage to Dr. Chen to show us the latest development in dementia care in Hong Kong. Dr. Chen, please.
Good morning, everybody. I'm Wai-Chi from Hong Kong, and I'm so glad to hear Joe's very informative and excellent talk. And this time, I'd like to highlight those developments we made in Hong Kong. And I'd like to divide my presentation into 2 parts. In the first part, I'm going to talk about the non-drug treatment for cognitive symptoms, and the second part for the BPSD. One of the most widely used intervention for cognitive symptoms are the cognitive stimulation, the training, and the rehabilitation. Cognitive stimulation refers to those activities that are usually conducted within a social context. And we emphasize on the enjoyment of the activities, which will usually involve some degree of cognitive processing. And for training, we focus on a particular cognitive domain, such as attention. And then we practice and practice and practice, because even among those who are having some cognitive deterioration, they may benefit from practice. And in cognitive rehabilitation is an individually tailored approach, and often involve using of external cognitive and learning strategies. So there has been a tons of evidence supporting the efficacy of cognitive stimulation. One of the more recent one is the systematic review meta-analysis by my colleague, Dr. Stephen Wong. We're so glad to be advised by Dr. Gloria Wong on this meta-analysis. We were able to identify 20 RCTs, and we found that the HSG was 0.313, and considering that cognitive stimulation is relatively free of any side effects, achieving this low to moderate efficacy is very exciting. And actually, there has been equally rich evidence supporting the efficacy of cognitive rehabilitation and cognitive training. Even more exciting is that the non-drug treatment works has a synergy with the drug treatment, like the first study, which is conducted by Chapman some time ago, who prescribed a cognitive stimulation and an anti-dementia medication called donepezil to those in the intervention group. And for those who are in the control group, they are receiving donepezil only. So then they met once a week for 8 weeks, and after that they will phone contact those participants on a monthly basis. And if we are doing nothing, then naturally the mini mental state score for those who are having Alzheimer's disease will decrease by 3 to 4 points a year. But after taking medication, they are having a much smaller reduction in the mini mental state examination score after 1 year, but they are reduced by only 2 points. And if you are doing cognitive stimulation activities together with the medication, the benefit will be even greater. So that's why it's not surprising that the NICE guideline requested that those who are living with mild to moderate dementia, no matter what kind of causes they were having, should be offered an opportunity to receive cognitive stimulation group therapy. And these are the pictures I received from my friends working in NGO and from a personal visit to their centers, and found that the local practitioners in the welfare as well as the healthcare sector, they are very good at delivering cognitive stimulation. Like on the left upper corner, they're having the paper pencil and the board games, and on the right corner, right upper hand corner, I took it before the COVID time, so that's why when people they did not need to put on masks. They were enjoying it when playing the games together in district elderly center, but now we are more commonly to use because of the social distancing, to use the computer or web-based cognitive stimulation. But are they useful? We're so glad that Dr. Gloria Wong, who is a key person of the JCJoyAge program, who actually looked into in this pilot study in a culturally adapted cognitive stimulation therapy. It's more structured, it's adapted from the United Kingdom with some cultural modification. For example, when we are discussing news, because some of the participants may be illiterate, so they were using pictures to supplement the news discussion. So on completion of the program in this pilot study, she found that around half of them showed no cognitive deterioration, and about a quarter of them had clinically meaningful improvement. She also recruited 25 group facilitators and family caregivers. and they participated in the focus group or in-depth interviews. And they reported that the CST was well received with a low attrition and a high attendance rate. Some cultural issues were identified. We found that the local older people, they were more conserved and more conscious in expressing their opinion, and they would prefer practical activities with reward and recognition to a pure discussion. And I understand that the Gory is now conducting a much larger scale implementation research in the Chinese populations, and hopefully we will get more information on this area very soon. And the local researchers also looked into cognitive training. It's Professor Timothy Kwok from the Chinese University. He and his group recruited 200 participants. In the intervention group, they received 8 one-hour sessions of active mind cognitive training program, which is compared with usual group activities in those DECC. And quite a number of them completed the study. And when compared with those in the control group, those who participated in this cognitive training program showed a better cognition as exemplified by the MATIS CDRS score, and have a better quality of life as exemplified by the SF-12 score on completion of the study. Dr. Grace Lee, who was used to affiliate with Kwai Chung Hospital, now she is in private practice, has studied into a cognitive rehab program called Errorless Learning-Based Memory Training Program. She was able to complete the program on 19 participants. About 6 of them received computerized errorless learning-based memory training program, 6 on the therapist-led program, and the remaining were waitlist control. And after receiving 12 sections of this individualized program, both those who are receiving the program led by the therapist and those who are using the computerized program did improve cognition. And while I could not identify Dr. Lee's further publication on this area, I was aware that she actually expanded the study to 75 participants later, and equally exciting results were reported. Another area that have been used to promote cognition among those who among older people physical exercise. Earlier this year, my group and I reviewed the updated clinical guidelines and the systematic reviews and meta-analysis and individual RCTs. And we found that the physical exercise is useful in preventing cognitive decline among cognitively normal older people. And for those who are having MCI or having dementia, physical exercise also helps them to improve their global cognition, in particular aerobic exercise. But there has also been emerging evidence supporting resistance training and mind-body exercise. But the intensity of exercise should be adjusted for people who are having different cognition. Because in one very well-conducted study, well-designed study in the United Kingdom, using rather intensive exercise to improve the cognition of older people with dementia. And to everybody's surprise, those who are receiving very intensive training actually fared worse than those who are in the control group. So we understand that for those people who are having already having dementia, they may need a program that is different for those who are having MCI or normal cognition. In Hong Kong, Professor Linda Lam from the Chinese University also looked into the efficacy of a very traditional but a very well-received physical activity. It's Tai Chi. She recruited around 400 participants who were either had this clinical dementia rating 0.5 or having a mild cognitive impairment. In the intervention groups, they will be practicing Tai Chi, and in the control group, they were doing stretching, toning exercise. 1 year later, about half of those who are practicing Tai Chi completed the program, and around 80% of those who are receiving toning, stretching exercise completed the program. And when compared with the stretching and toning exercise, participants who were receiving training on Tai Chi showed a trend for lower risk of developing dementia. The odds ratio was 0.21, even though it's not reaching a statistical significance. Their functioning level is better preserved, and they're showing greater improvement in delayed recall and their depression score. And then she concluded that the regular exercise, especially the mind-body exercise in Hong Kong, with integrated cognitive and motor coordination, may help to preserve the global cognitive function. But she also pointed out that because the adherence to exercise was much lower in the Tai Chi group, she needs to look into the logistics to promote the long-term practice and to optimize adherence. Nutrition is also important, and Sikis and this year published a very nice review, and they identified 2 Cochrane reviews on this topic, and there have been 5 trials on the vitamin B supplement, but there was no overall benefit on cognition. But they pointed out that there was one study examining the efficacy of vitamin B on people with mild cognitive impairment and high homocysteine, and found that in this group, they were showing positive results. And another 2 trials, very large trial, one is involving more than 600 people, and the other more than 340 people. They found that if we are giving a very high dose, 2,000 units a day, may delay the progression of functional decline, time to death, institutionalization, inability to perform basic ADL, and severe dementia. But the author also pointed out that it may be associated with significant adverse events like the dental events or falls or syncope. They also identified a systematic review and find positive findings for those who are taking DHA and EPA in 2 studies, only DHA in 1 study, and flavonoids in another study. But it's because of the heterogeneity of these studies, it's difficult for the authors to stimulate the evidence, to summarize them, and give them a very concrete recommendation. There have also been some single trials looking into the effect of low saturated fat or low GI diet, a low carbohydrate diet, calorie restriction, induced weight loss diet, or blueberry drinks. But they are all single trials, and they need replication. And naturally, these reflect the complexity of conducting nutritional intervention trials. The logistics is very complicated, and it takes a very long period of time. It's not easy to conduct a study on the nutritional intervention. So even though there is a very little locally adapted evidence on how the nutrition affects our cognition, I identified an observational study by Professor Alan Lee of the Chinese University, and he followed up more than 17,000 community living dementia-free Chinese older adults for 6 years. And found that for those, there's something all of us should be very familiar, because the Department of Health has been promoting the use of 3 servings of vegetables and 2 servings of fruits each day. And will it be useful? And he found that for those who are having 3 servings of vegetables, the odds ratio, they're having a lower risk of developing dementia 6 years later. For those who are having 2 servings of fruits, is even lower. But the best result comes from those who are having 3 servings of vegetables and 2 servings of fruits. But of course, it's an observational study only. We still need an RCT to look into whether the local nutritional intervention is effective. So But the method more effective are those using multimodal interventions. Linda conducted a study a couple of years ago looking into 555 older people who are having mild cognitive impairment. They were recruited from 4 different district elderly community centers. Group 1, they are having stretching and toning exercise, mind-body exercise, and aerobic exercise for 3 times a day, 3 times a week, sorry, it's 3 times a week. And for the cognitive groups, they were doing some board games or reading and discussing newspaper, again 3 times per week. The integrated group, they are having cognitive activities as well as physical activities. And for the social group, they were going to have enjoy tea and having film watching. 1 year later, all the physical group, the cognitive group, and the integrated group, they all improved. Their cognition are better than the control group. In particular, the integrated group, which involved both the cognitive activities as well as the physical activities, they have a significant improvements in the ADA score, in delay to recall, in the category verbal fluency performance. But it involved only 555 participants, lasting for 1 year. So that's why we are particularly happy to read the finger study, because it involved a larger sample. It recruited 1,260 older adults, and it lasted for 2 years. It involved something that we also did, like the exercise training, cognitive training. But in addition to this, they were offering vascular risk monitoring, like the monitoring of blood pressure, and they will also offer nutritional guidance and social activities. So 2 years later, they simulated 14 tests, neuropsychological test battery they conducted, and they found that for those who are in the intervention group, their scores is 25% better than those in the control group. It's very exciting because it's not involving any medication, there is no side effects, and by training your brain, playing some games, and doing some exercise, more eating healthily, having some social activities, you can have a better connection. But maybe you may think that, okay, they are having some Scandinavian diet. It may not be applicable to other localities in the world. So we are waiting for the Worldwide Fingers Network's results. Because after the finger studies, a lot of people were excited by these findings from the non-drug treatments. So a number of countries are now participating in the Worldwide Finger Network, adopting a similar approach, looking into the efficacy, maybe modified in their locality, including China. I know there is a center in Shandong, and there are also some countries similar to Hong Kong, like some places similar to Hong Kong, like Singapore. They also have a similar study, and so I hope in the near future we can have more results that can be applicable to Hong Kong to improve the cognition using the finger approach. And the second part, I'd like to talk about the BPSD non-drug treatment. BPSD refers to the symptoms that are commonly found in those with dementia, involving their perception, their thought content, and mood and behavior. And if you follow the person with dementia long enough, more than 90% of them would exhibit one or more BPSD, which is extremely common. So more than a decade ago, our group and our group looked into the prevalence of BPSD in the community. And we found that a number of them are very prevalent, like in particular, depression, apathy, anxiety, those mood symptoms, and some irritability and nighttime behavior, difficulty falling asleep, for example. And some delusion are also commonly found among the local people who are having mild cognitive impairment and dementia. Some may found that, okay, because of the dementia itself, the person are destined to have a BPSD because they're having dementia. What do you expect? They will be agitated, they will be yelling, they will be kicking at you when you're approaching him, but actually it isn't. As Professor Sadavoy just introduced to us how to approach the behavioral problems, and actually there are a lot of things that we can do, because while we could not modify some factors like dementia stage, the brain changes or neurotransmitter changes, we can of course change some factors related to the patients themselves, like is there an unmet need, or is he or she suffering from pain or having acute medical problems? They are modifiable. And some environmental factors, including the caregivers, are also modifiable. Like, are we having a knowledge about the condition? The caregiver suffering from stress? Is the environment over or understimulated without any routines and etc.? So we may approach the BPSD by understanding the etiology. So before managing the BPSD, we should define the target symptoms and consider whether there is any medical or psychiatric diagnosis, and identify the aggravating factors, including the environment, before we embark on the pharmacological or non-pharmacological treatment. So caregiver interventions are extremely important, and it is well known for many years, and like this meta-analysis by Professor Henry Bodati conducted around 2 decades ago, already showing that caregiver intervention not only reduce the caregiver distress and improve their knowledge, but they will in turn improve the patient's mood, so affect both the caregivers and the care recipients. So as Professor Sadavoy has given us an extremely nice overview of caregiver interventions, I'm not going to repeat it here. I just want to briefly introduce a few caregiver studies we had in Hong Kong. For your information, the one is by my group is we had home-based exercise intervention, because we found that exercise is good for your mood, but some exercise may have carrying a lower risk of injury to the participants, like Tai Chi, sitting Tai Chi. We do it home-based because the caregiver may have difficulty bringing the care recipients to our centers. So we are going to visit them and deliver a 24-week, an RCT lasting for 24 weeks. And the intervention group is a 12-step sitting Tai Chi. In the control group, we are only offering social contact. And we found that the depressive mood improved almost immediately after someone is visiting them and teaching them Tai Chi. Another study is by Professor Chen from, he's now with Chinese University and previously with Poly University. He designed very nice disease management program for caregivers. It's based on rich study as well as his own work. In the intervention group, there is a psychoeducation element together with support group, and the control group is standard care. The psychoeducational sections comprises dementia care, the family role in strength rebuilding, community resources. They were delivered by various professionals like occupational therapists, social workers, and etc. And they were culturally sensitive because they value collectivism over individualism, and emphasize on the filial obligations in the family and the kinship ties. Because by only supplying information is not good enough, he also arranged a support group. About a year later, he found that the caregivers showed a greater improvement in their quality of life and burden, and the care recipients showed a greater improvement in their symptoms as well. Professor Elma Au from the Poly University used another approach. She used a phone-administered behavioral activation. Again, the intervention group comprised psychoeducation, but also there was a behavioral activation module. In the behavioral activation module, she enhanced their coping skills like scheduling some pleasant events into their daily life, improving the communication, because she wanted to make it a sustainable intervention. She delivered it instead of face-to-face, which is rather labor-intensive and expensive. She delivered the intervention by telephone. And the older adults, mostly retired persons, they were trained as paraprofessionals, and hopefully it can these volunteers can help us to promote perpetuate this program. And then when compared with the control group, those who are receiving this telephone-based behavioral activation, they showed fewer depressive symptoms and have a lower attrition rate. And it's another very interesting intervention is by Professor Zhang Xiangdak from the Education University. Professor Zhang used a benefit finding group intervention. And in the benefit finding intervention itself is including psychoeducation, is information plus problem solving. And he also included a positive reappraisal of coping and finding benefits by restructuring the cognitive cognition, restructuring it to help the caregivers to construe the demands of caregiving in a more positive ways. For example, so some caregivers may complain that I was chained up at home because I need to look after my dad 24 hours a day. It's so labor intensive and so I hate it so much. But Professor Zhang will help the caregivers to look at it from a different perspective, like it's a chance for you to accompany your dad, or it's a chance for you to reciprocate the care you received when you were young. And not only by a positive reappraisal coping, it also includes mutual sharing in groups, and the participants, they needed to voice recorded their diaries and reflect on positive experiences in the group. So when compared with the control group, the BFI, they had a better depressive symptoms, less depressive symptoms and carer burden, and compared with the simplified psychoeducation. So you may wonder, what if I'm improving the caregiver's mood? Will it improve the care recipient's behavior in any way? Actually, Professor Zhang looked into it and just published his follow-up work, just published it this month. And actually, he found that for those caregivers who are reported fewer new PTSD at 4-month follow-up, well, these were actually mediated by an improved caregiver depression symptoms. So it's very important to improve somebody, the caregiver's depression. It actually did help those who those with dementia's behavior. Another group is the environmental interventions. We are first talking about the physical environment. It has to be non-stressful and constant and familiar, and it should be comfortable and encourage social gatherings. It should be safe for wandering instead of like when I'm visiting some nursing homes. When I first joined JCJoyAge, there were still nursing homes that tied the older adults to a geriatric chair, so whole day, because they were worried that they would be wandered away from the nursing home. But actually, we can make the environment safe for wandering. Like we offer places for ambulation, install digital locks and artificial partition or electrical bracelet or alarm system. And now with the advances in technology, we can always use GPS. Like it's a GPS shoes, then and on the right-hand side is a GPS vest developed by Poly University together with a Tonghua group of hospital. So it's comfortable, it's pretty, the vest itself, and it's also equipped with GPS so that the person with dementia can wander safely. Apart from the physical environment, we should also do something on the temporal environment. should be stable. The daily schedule should be stable, and so that the people with dementia can adjust to it better. And the environmental intervention, some like bright light therapy, daytime activities of passive heating, are also well studied to improve the behaviors. So behavioral intervention is one of the approaches we sometimes used. Like we first identify the target BPSD and then gather the information about the BPSD, what happened before and after that, and then we set realistic goals and make plans and encourage the caregivers to reward themselves, and continually we modify and evaluate the program. So some simple behavioral intervention we use, like the star charts. It's very simple. Could be understood by the caregivers as well as the care recipients, and easy to administer, and sometimes it helps. And there are a number of adjunctive therapies helping us to manage the BPSD, like those involving sensory practices like aromatherapy, and psychosocial practices like validation, reminiscence, and music therapy, and those who are structured care protocol like bathing and mouth care. Here are some examples. It's Professor Cordia Lai, who used to affiliated with the Poly University. She randomly assigned more than 100 dementia persons to groups like control, and also the life story approach is one of the approaches of reminiscence therapy. At the end of the treatment, she found that those who are in the intervention group, they showed an improvement in psychosocial well-being. Like they were able to express wishes in more acceptable way, they're more relaxed, and they have a more creative self-expression, such as singing, dancing, and painting. Music therapy was by Mr. Ricky Tuit, who is an occupational therapist of a nursing home. He conducted a crossover design study, RCT, involving only 14 persons, but it's quite interesting because he carried out 45-minute section 3 times per week for 3 weeks. Consisted of introduction, playing instrumental music, and exercise with music. And at the end of the intervention, he found that the BPSD exemplified by the Neuropsychiatric Inventory score improved with music therapy. And this one is aromatherapy, is by Ms. Pamela Lin, another psychotherapist working in my team before, and she was we got help from the nursing homes. So at the night shift, the intervention group will receive 2 drops of essential oil of lavender placed in a dispenser beside the pillow. And for the control group, they were having 2 drops of sunflower essential oil. And when compared with sunflower, which is odorless, those who are having lavender, they showed a better neuropsychiatric inventory score and Cohen's agitation score. But I think I've talked a lot about what have been studied in Hong Kong. But like I very much agree with the experts of non-pharmacological intervention professional interest area group. They published a paper this year. They pointed out that the overall evidence supports the efficacy of most of the non-pharmacological treatments. But the quality of some of these evidence is low. It may be the sample size was very small, the methodology is not good enough, the outcome measures may not be appropriate. Actually, they address this issue by advising us on the design, the methodology, and the reporting of studies of these interventions, like by proposing the rehabilitation treatment specification system. And I hope very soon, when we all work together by using a more appropriate methodology and reporting system, we are able to produce more robust evidence supporting the non-drug treatment for those who are having dementia or MCI. And here ends my presentation. Thank you so much.
Thank you. Thank you, Dr. Chen, for your sharing. And we are very delighted to see the emergence of evidence-based interventions for cognitive symptoms and behavioral and psychological symptoms in dementia in Hong Kong. And so we are now having roughly 5 to 10 minutes for our Q&A sessions, and our speakers are ready to take your questions. And now we have actually a few questions for Professor Sadavoy, and I think you have seen some of them. The first one is related to the simulation exercise. A participant said it's a great exercise and it seems to be very helpful for the carers. And how much training does the therapist need before they can deliver the intervention?
It's a good question. So just to tell you that our training program for clinicians has trained about 200 practitioners. The training is not just for simulation. It is it's a more, in order to do this, the clinicians need to be trained in how to manage the group therapy process within which the simulation and TST are delivered, because that's an important component. So our training is pretty intensive. It takes 4 days for clinicians to be trained, and then they are ready to go and run their groups.
Okay, thank you, Professor. And the other question would be that some of the dementia, some of the people with dementia are having behavioral problems quite often, such as stealing things or haunting, and their carers are facing huge stress in looking after them. So could you share some of the experience in helping the carers to reduce their stress, please?
Right. So this is very much, of course, how problems are presented to clinicians, and it comes in a rather general form that is attached to a word like stress. So I think that stress reduction has different elements to it if we're able to do it. We can't always do all of it. Some of it begins with the process of reviewing the specific issues that the caregiver is facing, trying to define where the problems are for the caregiver in the midst of those problems, and then working with them to look at solutions to them. So, for example, with someone who is stealing or hoarding, one might begin to look at community resources to occupy a care recipient, a person with dementia, to divert them from their activity. Sometimes it requires a neurobehavioral assessment to see whether some of these symptoms, for example, hoarding and obsessive compulsive behaviors, may be amenable to medication intervention. Sometimes the caregiver themselves, in the midst of this, needs to learn techniques to reduce their stress, such as mindfulness intervention. We have a program like that we incorporate into our programs, and so on. So I think that education of the caregiver, understanding of what's going on, attacking the specific symptom and looking at where the potential elements of intervention may be around things like hoarding and so on, looking at medications, that whole package is a way of conceptualizing and thinking, I think, about how to manage these very complicated and complex things. The final thing is that caregivers are very alone and isolated with these things frequently. They don't know that these kinds of problems are quite common. And so bringing caregivers together into active engagement with one another is an important component. I'm very impressed with the work that I see going on in Hong Kong. Wai-Chi's presentation was, I think, a tour de force of bringing together a whole complex of both information and methodologies. And I want to thank him for that. I also want to thank him very personally for all the kindness he's shown to me personally during my time in Hong Kong. That's just an aside.
Thank you, Professor. And there's a question for Dr. Chen. And in the simple slide, idiopathogenetic model of behavioral and psychological symptoms of dementia, environmental factors did not include the physical environment. However, would you consider that physical environment can be a modifiable factor that worth actively pursuing as part of the non-pharmacological intervention, particularly in the densely populated elderly home facilities in Hong Kong?
Yes. Sorry. I didn't know how to operate the button and press it wrongly. Sorry about that. First of all, I have to thank Joe. And every time I listen to your talk, I learn something new. So thank you so much for your enlightening talk. And I totally agree with Calvin that the physical environment is so important and is very challenging in a crowded city like Hong Kong. And because when I'm visiting the nursing homes, they have to use every bit of the space already, and it's too difficult for them to do something on the physical environment. But having said that, they are still trying their very best. Like, as I mentioned, the physical environment for those who are having dementia should be non-threatening, constant, and familiar. So even though they could not, like what we see in most developed countries, when they can like bring their own bed or their own cupboard into the room, our colleagues at the nursing homes, they were trying to make the person feel familiar with the places, like posting their pictures of the family, posting up the names of the resident, or even using a color route line on the floor, guiding the person with dementia to go back to his or her cubicle. And they also make use of the limited space. I have seen people, some very brilliant colleagues at the nursing homes, to use a very tiny plot of land to build an outdoor wandering path. Not big, very small, but is big enough for the residents to wander about. And they also use the digital locks and camouflage exits to reduce the chance for them to wander away from the nursing homes. They are already doing a lot of work. But yes, we should look into any possible or feasible interventions that can be used in a crowded place like Hong Kong. But it requires a lot of work because it needs a lot. We have to think outside the box, and we have to persuade the already extremely busy nursing home colleagues to help with us, the research team, to work on this newer intervention, which may work or may not work, but already they were overloaded by the everyday care for those for the residents. It may not be easy for them to spare extra time to work on this unless they are really simple and they can see the benefit of carrying this out.